Hey, if you have FND and you've been told maybe that you're being dramatic or that it's not real, that you're making things up, that your seizures aren't real or they're pseudo seizures or psychogenic seizures, we are going to bust some myths on all of these topics today because I have heard extensively from you, folks that have FND, as well as other clinicians that are like, I want more understanding here. I need to really understand. And I have to tell you, I just got off the phone with a lovely former PT student of mine that is working in the ICU. And she has a patient that has what I would say, quote, pseudo seizures. And the team actually had said together, like, oh, it's one of those. She's making it up. And I was so lucky that I got to hop on the phone because I was prepping for this exact topic. And we talked about the case. I gave her a ton of resources, of which I'm going to chat about today. So things like pseudo seizures. I'm going to talk about why that's not the accepted or really an appropriate term anymore. And I wanted to share some of the other things that people had shared with me where they're frustrated maybe with their care. For example, they might have to explain it to everyone because people don't understand. So they're looking for mental health care or physical therapists or occupational therapists that actually understand FND. Managing stress and flare-ups. So people want to know and want a mental health professional that can help them manage those things. Because I put this question out for mental health. Being told I'm faking it. This was from a lovely OT. The other clinicians calling things behavioral, meaning this is kind of a way the person's manipulating someone. And I'm not to say that people are never manipulating, but I will say 9 times out of 10, they are not. And access to care, hypervigilance, and hopelessness, going to therapy and it's not working. So these are all things that are challenges people shared with me, mental health challenges and FND. And what I find amongst clinicians is, one, we didn't learn all of this in school. So I didn't learn this. I was in PT school over 20 years ago, and I learned conversion disorder. I learned that anybody experiencing some of these unusual symptoms it's actually completely psychological, usually some sort of sexual trauma. This is, again, what I was taught. So I don't want to fault anybody that maybe has this prior understanding. That's what we were taught because that's all that was known and understood at the time. But honestly, there was a lot we didn't know about stroke and MS and Parkinson's also 20 years ago that has evolved so much. And so has the world for functional neurologic disorders. So first of all, if you're a clinician that has still been living in the world of pseudo seizures and conversion disorder and psychogenic movement disorder, I don't fault you. That's probably what you, like me, learned in school. And it's probably actually what's still perpetuating in your healthcare system to some extent. I want to empower you, however, to keep learning and growing because there's so much out there now that we know better and we can do better. So I'm going to share some resources with you today that you can literally take to the hospital, to the ICU. You can start having journal clubs, start educating other clinicians. So I just see a few comments coming in here, so I just want to take a peek here. So my doctor called them pseudo seizures, and this was from the Cleveland Clinic. And I was just at the Cleveland Clinic. Amazing folks. And you know what? And again, I will say the seizure world is not all on board with a new term, but there has been a really big push to change the term to functional seizures. So I think there's more coming that way. Somebody else asked, do you take calls? So yes, we do consultations, we do mentoring with clinicians, all of the time. So we do take calls and we do mentoring with clinicians. We also help coach patients to get them connected to resources. And so you can send me a message if that's something that that you're interested in. And then, okay, my favorite, hi Indy, what the FND? I read about FND in my psychology textbook. Yes, the irony, it was still in as conversion disorder. And that was a textbook from 2023. So yes, there's still some misnomers there. And you know what I want to say, Indy, especially in the psychology community. So I think there's a lot, and this is why we are really trying to get the word out, particularly to psychologists, to really understand F&D and all the pieces that go into it, because psychology can be a big part of the recovery process too, even if it's not a psychological disorder. Your location is in Southern California. Yes, we are in Southern California in the LA area. So we are, wow, lots of comments. Hey, thank you for joining. We see a lot of patients in the emergency room, and it's so challenging to help in this setting when the medical model is working against us. Also on inpatient rehab. Paige, I just like, my heart goes out to you. I know it is so hard. So I'm giving you resources today. Again, I chatted with one of my former USC students who is a rock star, who's in the ICU. And, you know, one little step at a time, I think is going to chip away at some of this inaccurate information. So I want to start with this. I was already planning this before this wonderful student called me today. And it hits on this exact topic. And this is from 2020. I will tell you the F&D Society had a meeting this year. It was in Italy. I did not get to go in person, but I attended online. And they talked specifically about this topic and how we need to change the terminology. But this article was from 2020 from a group all over the world. So Iran, Philly, Verona, Italy, and London, talking about why we need to change the terminology for psychogenic non-epileptic seizures and making the case for functional seizures. You could throw in here other things that are a misnomer. So psychogenic or pseudo seizures is another one that is a misnomer. So this was a review where they actually did a systematic review of literature looking at the terminology and then went into describe why the term psychogenic is no longer helpful in this case. So I want to talk about some of those reasons. And one of the reasons is that psychogenic was the term that was used because they didn't really understand what was happening. They just knew it wasn't epileptic. And so assumed, and which is a very dualistic representation of a disorder. It's either a structural lesion or it's psychogenic. And that dualistic understanding of the brain is actually kind of a myth. Not even kind of a myth, it is a myth. So the brain is not really separated that way. There's a lot of network interactions. And this representation of the disorder is just not supported in the research anymore. There's not one psychologic center that is causing the psychogenic non-epileptic seizures, what we would call functional seizures. This is why that term is out of date. It no longer represents what's actually happening. And in fact, as research has grown, we see many areas of the brain that are involved. Maybe it should be called multifactorial seizures, but not psychogenic. It's just too narrow. And again, I'm not going to really fault folks for using that term a long time ago. We didn't have the imaging and testing in place to really be able to understand what it is. I want to share Stella's comment here. She's partnering with clinicians to work on educating emergency departments. So Stella is a huge advocate for people with FND and for clinicians to know and understand it better. There's also, by the way, a really great article out about FND in the emergency room. So I'll have to share that at another time. What we do know, so again, this article, separating epileptic from functional seizures, we do know that they're not epileptic, meaning they don't have those epileptic form changes on EEG, but the mechanistic cause of them is not purely psychogenic. And the term functional seizures, this is what they say, it's neutral in regards to the etiology and the pathophysiology. By the way, a lot of folks with epileptic seizures also have functional seizures. This is why we shouldn't be having this dualistic idea about one or the other. It's often and. And so what they say is the term psychogenic or dissociative or conversion seizures, that's another one, I hadn't heard of that. It gives a very specific cause that falls short of the evidence that is a very complex and potentially very heterogeneous condition. Now, is it true that some people might have a psychogenic cause? Yeah. I will say from working with folks with functional seizures for a while, I see that it's multifactorial. I do see that people might have more seizure activity under stressful conditions. But I also see they might have it when their blood pressure drops. Two very different things, right? So we should get rid of the term that is too narrow, psychogenic, and change it with the term functional. Another term, dissociative, has been used, but some people don't experience dissociation in their seizures. And again, that's why a broader term of functional seizures, which is really getting at the multifactorial and functional connectivity issues that might be had, is very helpful. Now, another term that has been used is non-epileptic. It describes that it's not an epileptic seizure. It's not very ideal to call something the non of what it's not, right? So we don't say somebody that has weakness is non-strong, and we don't say that people with functional seizures have non-epileptic seizures. So again, they propose the use of functional seizures, and this has been shared again and again and again. And as Stella is sharing, the biggest challenge is reaching doctors who've been out of school and in practice. Often they're not open-minded to learning the unknown because they believe they've studied it all. I think that's true, and I wish that weren't the case. And what I will say, because I've been in the hospital setting, I've been in the acute care setting, I've been in the rehab setting, every setting I've gone to, I have found the one person that will listen and be open to change. So even though there might be some folks that are resistant to learning and to experience change, I don't let that get in the way of us moving forward and finding those people that are open to it. And then I just say, don't go to those doctors. Now, if they're in the emergency room, they're in the hospital, it can be really challenging. But as Stella says, it starts with just one. That's all it takes. And I say this because I talk to acute care or rehab therapists all of the time that are very frustrated by this. And so are our patients, right? They're so frustrated by this. So myth number one that we are busting with this article, and more, by the way, there's so much research now looking at fMRI imaging and what's actually happening in the brain for people with functional seizures. And what we are busting here is that functional seizures are pseudo. They're not faked. The person has no control over them. They're not purely psychogenic, so we get rid of that term. They're not a purely conversion phenomena. They're functional seizure. They're likely multifactorial, and they're happening because of some connections gone awry in the brain. So that is myth number one. I want to share a different one here. I'm going to share a couple of great articles. So I listed them all here. Oh, it looks like I didn't get the tables that I wanted to share. But just in case you wanted a few things to share with your medical team, number one is what is called why FND is not feigning or malingering. And this is the number one myth that I hear. And I particularly hear it about hospitals or ER, is that folks see somebody and put them in a box of faking it, or they're dramatic. Or maybe they've had childhood trauma, and maybe they have, but gosh, maybe they haven't. Maybe we should not assume that about all people. So I highly, highly recommend this particular article. It's a really great one. It's available free, full text. I'll put it in our newsletter this week. If you're not on our newsletter, if you respond to the recording of this with newsletter, I'll send the link to send that to you. The second one, as I mentioned, is that terminology for PNES, making the case for functional seizures. That's just the one that I just reviewed. And then this third one, and I was hoping I had some tables to share with you. This one just came out. Let me pull it up here. It was a really nice review, again from a multinational group from the UK, Greece, Morocco, Romania, and I think I got them all, but how cool. Okay, so that's the third one here. Understanding functional neurologic disorder, recent insight and diagnostic challenges. And I wanted to share this because it's a nice review that, again, you can use for a journal club, but you can share with your fellow clinicians. And it goes through the epidemiology, the etiology, and has these really lovely tables that I thought I could share with you here, but it looks like I cannot. So I apologize for that. So I'm going to talk you through it. So one of the things that was really nice in reading about this is just looking at the general epidemiology of FND, and both in kids and adults, and we see kids and adults as well. One thing that was from a very recent study, by the way, that looked at FND in kids was that 97% of children, or I'm sorry, this was in a study, not 97%. In a study of children with FND, of 97 of them between 5 and 15, the median age of onset was 13 years old. That is a common age that we see, 13, 14, 15, 16, something commonly we see in our programs. And they acknowledge that the world the clinical world, the healthcare world, has a hard time distinguishing F&D from faking or malingering. Now, I'm going to tell you from my personal experience, I don't think I've ever met somebody that was faking or malingering their F&D symptoms. If it occurs, it is the teeniest, tiniest percent of people. And I'd be much less worried about that happening versus that, like, I'm missing that somebody is faking it or malingering for some reason. It's just not the common finding. However, if you talk to folks that are working in the medical field, that's kind of their default, is like, this person must be faking. And I get it if you haven't seen it before and it looks very unusual and you can't understand why it's happening. Sometimes that's where your brain goes. But I will tell you, that is just not the case. We now know with neuroimaging studies that there is this complex neural circuitry that's involved in F&D, and none of it has to do with faking. And some of those studies, by the way, they came out in 2009. It's been almost 20 years, right? So it's been a very, very long time. Some of the other things that have since come out in understanding F&D is that there might be abnormalities in neurotransmitters. There might be in inflammatory markers. I talked about that the other day. And as Ethnicity Gardens is saying, like, literally nobody could fake this. I agree with you. F&D would be extremely hard to fake. It also would be extremely hard to voluntarily do the things that happen in F&D. I know and I understand that in the medical field, when people see the symptoms that are occurring, they believe the person has voluntary control over these because they're unusual. There is no way somebody could voluntarily do some of the things that we see in F&D with dystonia, with myoclonus, with tremor, with weakness, with functional seizures, etc. So part of this is a shift of mindset for clinicians to kind of go from, and I don't know what it is. I have to tell you, I am an extremely optimistic, believe the best in a person. That is who I am. I do see and hear, and I have because I've worked in healthcare for my entire career and I've worked in hospitals. I hear from other people, they're a little more cynical. Like, ooh, this person must be faking it. They're trying to pull a fast one over me. And people, they are not. That's just not what people are doing. It's not voluntary. It's not faking. And in fact, there are these changes that are occurring in the brain. Now, another myth, and again, I'm going through some of the points of this great paper. Another myth is that F&D is due entirely to trauma. And there is in most of the studies, there's a good 40 to 50% of people that have no history of childhood trauma. There is 50% that do. So we don't want to ignore that 50% entirely. If you compare a group of people with F&D to people without F&D, there is a higher incident of trauma. However, we don't know for sure that trauma caused the F&D. There's usually, again, it's multifactorial. We should zoom out and really try to understand the person. And we should not be digging deeply for trauma. This is apparently how I dig. I was like I'm digging into a wound, like doing wound care. We shouldn't be digging for trauma. It might not be there, and the process of digging could be quite traumatic. And yeah, as what the F&D is saying, especially teens are accused of it. So Indy, yes. I think this is another piece that is really important. People think kids and teens are more likely to be faking it. They might be trying to manipulate things. And not to say there maybe are a small percentage of people out there like that. But again, I'm a parent, I'm a mom, and I think it's really important to get curious about what might be happening for a person for them to have symptoms, or even if they're having some sort of I'm going to say behavior, what a medical professional would call behavior. If I see something, if they're acting a certain way, if they're saying certain things, but certainly if they're having symptoms, I'm going to get really curious and try to understand why. My go-to is not to assume that they are faking it. It's not to assume that they're trying to manipulate me. I'm sorry, I just don't think that's how humans as a whole operate. Now, yes, there are criminals out there. And you know what? Maybe a criminal is going to pull a fast one over me someday. I'll take it so that I will believe most other people who are truly not trying to pull a fast one on me. So very good. Yeah, and as Stella is saying, so much of the trauma is from the diagnosis process and all of this misunderstanding and invalidation, not before the disorder. And someone else is saying, well, trauma history FND individual that I blocked out for decades until I did EMDR. And I just want to thank you for sharing this. Okay, so I see some other things. I want to get through some other key points and I'll come back to your comments here. Okay, so we were talking about trauma. Here's another piece. I found this one so interesting. Again, this is from the article in 2024 called Understanding FND with Recent Insights. This part is called the role of personality traits, because we might hear from some people, well, there's a certain personality that gets FND. Well, no, actually there is not. So they went and reviewed the studies. And again, they found one, that some folks get FND without any identifiable stressors. Two, they might not have adverse childhood or adult trauma. And they're kind of disputing a tons of it. Birth order. Somebody actually asked me about birth order. That one has been disputed as not related to FND. Here's an interesting one. And again, I'm not a psychologist, but the studies focusing on personality disorders specifically found some to be more common in FND, but still only present in a minority of patients. So this shouldn't be the first thing that we are looking for in FND. So I think particularly for our mental health providers, the idea is not that the person needs to be diagnosed with multiple causes of their FND that are psychiatric, because it's just a very small percentage of people. The person needs support. They need understanding. They need strategies to help them through the day. They need help coping with a disorder that comes and goes. It's quite distressing, and they need you as a mental health care provider not to be trying to see what their personality disorder is, but to give them support. Here's another really interesting thing. By the way, another one of the studies indicated no consistently found personality traits in people with FND compared to controlled subjects. Okay, these are just the reviews, and they're dispelling all of the myths. Now, this is a really interesting one that I find really interesting, and I see it clinically, but there are medical and surgical comorbidities more often in FND. And what we see clinically and has been talked about in the literature too is the effect of anesthesia on the nervous system. And I bring this up because my rock star former PT student who's working in the ICU and learning and getting better at all of this said this all happened after the person came out of anesthesia. And we know and understand that anesthesia can disrupt some of these brain networks. It doesn't mean don't get surgery, but we might recognize that some of these things can happen after surgery. So I thought that was really interesting. So this is their summary statement, by the way, to bust this myth. While FND has been historically linked to various predisposing factors, including adverse childhood experiences and certain personality traits, the overall picture emerging from recent studies is that these factors, while significant, do not present in the majority of patients. The etiology of FND is multifactorial. It's not that you're going to have one single predisposing factor. Oh, I just want to say amen to that. Okay, so I'm going to recommend you take a look at this article because I found it really, really helpful, because in the next section, they actually go through these lovely tables of some of the different networks and models that are implicated in FND. Changes in the limbic and salience network, self-agency and multimodal integrations, attention and sensory motor circuits. They talk about all of those, and they talk about some of the models that have been proposed to explain FND, and kind of the current leading model of understanding is this predictive brain model. But I would say we still don't fully understand that this predictive brain model might be a piece of the pie, but there's probably other things as well. And again, this article just came out in 2024 as a review, Understanding Functional Neurologic Disorder, Recent Insight and Diagnostic Challenges. It is free full text, and I will put it in our newsletter this week. And I want to get back to some questions. Okay, so I think it's Tammy. Can you explain FND diagnosis with motor skills after an automobile accident? How is that possible if clearly MRI x-rays come back with some findings of injury to spine, upper and lower? I don't know this particular case, so I can't say for sure about anything. That's what I'll say to start off. But I will tell you, people develop FND after injuries and accidents and after real things happen, real injuries happen, fractures and nerve injuries and back injuries and all of that, which, by the way, FND is also real. So it's, to me, it actually makes a whole lot of sense that FND would occur after some kind of injury. And I think I put my book back up here, but I always bring this book back when people ask about injuries in FND, because Oliver Sacks wrote a book on this. Had an injury, it was a hiking injury, had fractures, had a nerve injury, and then developed FND after it. There's this really great quote by Mark Hallett, movement disorder neurologist, who said FND is kind of what would be expected to occur in a predictive brain situation. And so it happened to Oliver Sacks, a very, very prominent neurologist. It could happen to any of us to have an injury, to have a neurologic diagnosis. So by the way, FND is more common if you have a neurologic diagnosis. So migraine, Parkinson's disease, MS, etc., tremor, essential tremor, for example. It's common to have FND and those things. And something that is really important that Dana shared with me today, she reminded me to remind clinicians that not all things are FND. So if a person has FND, it doesn't mean that all of their symptoms are FND. So if they have migraine, they should be treated for migraine. If they have a nerve injury, they should be treated for that as well, and treated for the FND. Because if you ignore the FND and don't get treatment, unfortunately, it can kind of get worse. So you want to treat it. So people can have Tourette's syndrome and FND, and they could have functional tics, right? And you know what? Both of those can respond really well to therapy. That's what I would say too, if somebody has had an injury after a motor vehicle accident, you know what? Like rehab for all of those things together would be really, really helpful. What a great question. Okay, just going down. Oh, Stella asking me to dive deep. I love if you did a take on multiple personality disorder versus dissociation and regression. I think that's way out of my expertise, but I'm interested, Stella, and I might have to talk to somebody about that. Really great question. And then Stella asking about my blue necklace. So I'll tell you about my blue necklace. So I took a trip with my husband for our anniversary. It was our 25th wedding anniversary. And we went to New Mexico, which is a place I've always wanted to go. And I fell in love with it. And this was one piece that I kind of got to remind me of it. And I'm going to tell you this, that weekend, you kind of think anniversary trip and it's going to be all lovely and good. My husband and I'll spare you the details, but we actually got in a really big argument. And not even an argument. It was just like a disappointment, right? And it was really, really hard because you're like, oh, we finally got away, and then this happens, and then we worked through it, and it was our last day there, and I actually got this afterwards, and it was this reminder to me. So I'm sorry, this is a super long story now, that you can have both. You can have all of the joy and all of the good, and you can make it through the hard things. And anyway, that's such a life lesson and marriage lesson for me. I have an incredible husband. Okay, coming back down. Yes, Sophie here. A high percentage of people with FND are neurodivergent, yet autistic ADHD isn't seen as faked, despite these conditions not seen on MRI. Yes, but we all accept the brain is working differently in neurodivergence. Beautiful analogy. We could make this analogy for many things, Sophie, but I'm so glad you brought this up, because this is also newer in the literature, that the incidence of FND is higher in those with autism, and the people with FND, there are more people with autism in that kind of combined group than the general population. And I think it's not surprising to me. It's kind of a different brain, and a very cool brain at that. And connections might be made differently, or neuroplasticity might happen a little differently in those brains. That's a whole nother topic. But yeah, imaging doesn't show up there yet. People aren't saying they're faking it. Same with migraine, headache. A lot of things don't show up on imaging, and they are definitely not faked. Parkinson's, by the way, that doesn't show up on an MRI. So, yes, we really need to change our understanding there. What a great comment. And then Chronic Pain Hacker was also saying, I was diagnosed with personality disorder years before punk small neurological disorder diagnosis. I'm not sure if you were saying FND there, but I kind of like punk small neurological disorder diagnosis. Yeah, that's, I think that's interesting. So again, there seems to be a minority of people that might have that. And great question from what the FND, and is FND something you have for life, or does it usually go away on its own? Now, this is a really good question. A lot of things don't just go away on their own, particularly when we're talking about a connection issue in the brain. In simplest terms, it can be rewired, it can be reconnected, positive connections can be made and reinforced. But that doesn't just happen by sitting on the couch usually. It takes figuring out what has been kind of gone awry and what is needed from maybe the sensory system, autonomic, motor control, lifestyle, psychosocial. Maybe there's some physical impairment pieces in there. That's our whole pie chart, by the way, to rewire, to improve those connections. Now, here is something that I would say. Most people with FND don't just have FND. And back to Sophie's point, if they have a neuro divergent characteristics, so maybe they're autistic, they have ADHD, those are part of them. That is their brain. And we actually do not work to take that away. And I will say this is a reactive philosophy of a very neurodivergent affirming practice. We look to see what that person's brain and body needs to exist in the world. And as opposed to trying to change those traits or change that brain. So when I'm talking about brain changes, I'm talking about the learned and developed FND patterns that occurred, not the special brain that you had before FND. That special brain is your special brain. We just want to help rewire, maybe unlearn some of those pieces, and you might still be living with hypermobility, if that's something you have, or POTS, which both can be managed and a person can live well with them. ADHD or autism, those are things that we can improve how you live with them, but we're not going to take that away. I will say there are studies, for example, in functional seizures, in younger kids and adolescents where they are completely seizure free. So is it something that after treatment, by the way, so that's with treatment, completely seizure free, and they're living their lives without symptoms? That can occur for people. My experience is that people have much more than FND. So the FND, yeah, that might get a whole lot better. But your brain and body are still things that you need to learn and understand and manage. That's such a great question. Camille says, hi, I'm Camille, just finding your page. I'm a young person with FND. Was in the short documentary and will be in the long one as well. Glad to see you. Yay. Hi, Camille. And yes, we're also a part of the short documentary. I don't know if we're in the same documentary, Camille, but I just want to say hello. My 7-year-old was diagnosed with FND. There's not many resources in California for children. Is it not common in children? Well, it is. And in fact, this recent study review that I just read, it was 18.3, this was from 2023, 18.3 per 100,000 children. That was the annual incidence. So we do see it in kids. I'm going to say 7 is really young. And I will say I am always skeptical of a diagnosis. I'm not going to lie. When people come to me with FND, I'm still skeptical, but I'm skeptical if they come to me with MS. I want to confirm it is indeed FND. I'm so sorry that we don't work with kids that are 7 years old, because I would say, oh my gosh, we could help you, but we go to as young as 12. And that's just our background and training. But send me a message and I can send you some other resources for kiddos, because there are a lot. And kids can do very, very well with treatment. Very well. Okay, all these great questions. Is it fair to say that FND episodes can be triggered by activating the nervous system? Mine seems to be triggered by anything that makes me feel unsafe, from loud noises to situations, and I'm curious. Well, first of all, Wild Wisdom Arts, that's a fabulous name, and you are not alone. Those are really common triggers for FND episodes, and I love how you already have insight into that. Things that make you feel unsafe. So startle response, for example. Now, that's not the case for everybody. Not everybody is kind of in a more activated state. Some people actually are in a very shut down state and don't respond to stimuli. And that's actually the issue. So I want to say what you're saying is common, but that's not certainly the case for everyone. Now, when you say that as well, one, you already have a lot of insight. So you're probably already finding things about yourself, about your psychological safety and your sensory needs that are probably going to help you a lot. And if you haven't already discovered that, I would definitely work with PT/OT psychology to explore that and understand for you what your brain and body needs. Yeah. Oh, yeah. Okay. So what the FND says, woohoo, neurodiversity win, autism and ADHD here. Okay, Indy, I also can't wait to meet you. But the autism and ADHD frequently go together. It creates a pretty fantastic and elastic brain that is set up almost like a little perfect substrate for FND. And it's together, we figure out what your brain and body needs so that we can support those specific needs. And you'll have a lot more control over your symptoms. So excited to meet you. And Stella is just also saying, Wild Wisdom Arts, when your body experiences a sensory input that stimulates a similar sensory input from a traumatic experience, our body gets confused and goes into fight or flight. Oh yeah, and Sophie is saying too, me too, ADHD, migraine, restless legs, etc. Yeah, welcome to our world. This is what we live in. Multiple diagnoses. Oh, and chronic pain hacker says, I was 8 when I developed FND. That is a very young age. And again, it happens in children. It's less frequent in a really young child. Sharing too, my 7-year-old experiences pain and loses mobility in her legs and arms. Oh, and I'm going to tell you, these are the things every clinician should screen for when a child is having pain and loses mobility. They should definitely screen for hypermobility to see if that's causing it. Excuse me, I think I'm talking a lot. So screen for that. Not everybody has hypermobility, but by the way, it comes with autism as well. But sometimes that can be an underlying piece. And if it's caught early and supported, people can do really well. And what the FND is saying, do symptoms usually stay the same, or they can fluctuate, change? They can fluctuate, they can change, and they can get a whole heck of a lot better. And this is, Stella has been through our program and is now an FND advocate, can attest to this, as can many other people. When you learn about what your brain and body needs, you can take care of those needs. You can manage things yourself. You can have tools and strategies so that you might no longer have symptoms. Yes. Oh, Sophie, and this is one of the common myths too, FND in the hands of a clinician that doesn't understand what it is could be used as a catch-all for things they don't understand. Things like PANDAS, POTS, MCAS, we frequently see those with FND. So we see FND and we see those other things. And that's why as clinicians, we should screen for those things so that we can facilitate treatment of those things. Now, the good news is a lot of the treatment is similar and can really help people. Yes, so I did know this lovely person is in our FND membership. So I wanted to give an option for folks that are not in California, not able to do treatment. We have an online membership for people with FND where we do education classes every week. We do movement classes. We have a dysautonomia class. We have a mind-body class, but mostly education. Stella's an advocate in that community, and it's a game changer. She's saying, I'm better 2 weeks. I feel better and I move better. Incredible. And what great questions. So I'm going to take a couple more questions here, and then I got to go. My daughter's playing in a CIF game tonight, so I got to go watch her. So this is a really good question, though. I currently have a patient with FND, and she doesn't accept the diagnosis. Any insight on how I can help her? First of all, you know what? Would all of us want to accept this diagnosis, particularly if people have told us it's because we're crazy and it's all in our head and that we're faking it? I think if I had physicians telling me that, I wouldn't accept it either, because it's not true. So sometimes when I see that people are struggling with the diagnosis, they haven't had a really good diagnostic process with clear, positive clinical signs that are sensitive and specific to FND, a clear explanation of what it is, and they reject it. And I don't blame people for rejecting it if they haven't had that clear diagnostic process. And if they haven't, then I try to get them to somebody who can do that with them. And some folks, they've had zero testing at all. And there are some physiologic markers now for FND, particularly for tremor and myoclonus. And that would be really appropriate to do. So first of all, I would empathize with the person of I understand why you might reject this disorder. And I will say, as a clinician, as a physical therapist, they also might not quite be ready for the rehabilitation process. And that's also totally okay. I've had patients literally 6 years ago, they're like, I don't know, I think it's something else. And then come back 6 years later going, yep, I tested everything under the sun for 6 years, mind you. I hope not everybody needs to go through that process. And I really think this is FND. Now I'm ready for help. Okay, you can plant the seed and help that person when they're at that right time on their journey too. So, Great. Stella is open to sharing. Yeah, it took me years to accept it. Yes, I have to practice radical acceptance over and over again. Thank you for sharing that. Yeah, really, really great. Yeah, and Ethnicity Garden said too, I was pleased to get my diagnosis. It gave me somewhere to start. For other people, it's a relief to finally understand what has been happening and to be able to start taking a movement in a direction forward. So thank you for sharing that too. I have lost my voice with all of your great questions and all of your wonderful, wonderful insights. It's your questions, it's your comments that drive me to keep spreading the word, to keep sharing with clinicians across the world, so you can have really, really good care. So thank you so much for sharing your stories and for being here. Thank you so very much. Have a wonderful, wonderful evening, and I will see you again soon.